Okay, how so? Any examples?
I don't think we followed what each other was
No.
necessarily doing.
I don't think I designated
Maybe put
one of
that
my
more
jobs
defined
is
a
you
little
do
Yeah.
blah, you do blah.
Yeah.
And I'm just
I
like,
ignored
saying,
the
has
other.
that happened yet? Has that happened yet?
I think some of that is also the result of because we didn't physically do it, so then you
Yeah.
say you're doing it, but we don't know. Okay, because you can't see it. The fully in
Yeah.
it, but we
Yeah.
don't know.
Yeah.
So I think it's a little bit of that as well.
And
Sure,
things also
so-
worked faster there. Like I was like, oh, okay, we'll put the Foley in. Well, here, I'll just put a fake thing on there. Like you're not
Right.
actually doing it. So that would have
Sure.
taken me 4 minutes. So I had the other 3 minutes to be like, okay, well,
So
what
let me
next?
just reiterate that it's important not to blame the mannequin,
Yeah.
okay? We're doing our best to make it as real as we can. The fact is that no one said Foley is in, right? That's the communication piece. You need to close the loop. Even if there's a real patient, you still need to say Foley is in. Okay, so I think closing the loop of communication would
Well, I think we
solve some
did that
of
well
those
with
issues.
I
like,
think we
okay,
did that
no
super
IV
well.
in, no IV in, no
Okay,
IV in.
I
I
heard
tried
that.
to
Going
clarify
out of
a few
IO
times
in.
because I find that the talking at the head of the bed was really quiet and I could hardly hear because
Oh,
really?
I could
Right.
hardly hear Lindsay. I was like, Lindsay, wet people, and you're like,
Yeah.
what?
Good. So part of communication, right? Speaking loudly, clearly, making sure everybody on the team hears. So it's good for the recorder to say, "I can't hear you. Speak up if you can," to help close that loop of communication. Everything should go back to the recorder, who then has everything documented, of course, but also the team leader can then be aware when everything is said out loud. So I think closing the loop of communication would be one thing that I would stress for this group. Okay. Anything else?
Fun to actually use the IO. Never actually used it.
Yeah. Did you use the gun?
Yeah.
Yeah.
I myself have never.
Pretty
actually
easy,
used
isn't it?
Yeah.
Yeah. Pretty intimidating putting an IO in, but it's very easy with the IO gun. So that's one of the things we wanted to kind of just reiterate here today. Don't be afraid to put an IO in. Easier than an IV.
Mhm.
I think the one big letdown that I kept on thinking of but kept on ignoring was the mother, like sitting around all
Yeah,
day.
that was
like
a
there was
big.
like sporadic, like he'll be okay, it's okay, his heart rate's this, it's blah blah blah. I always, especially with children, you want to get the parents involved as much as you can.
Sure, yeah.
And instead, like I was just like, excuse me.
You know what?
Don't make eye
So in
contact.
real life, when we're not all trying to be in on the mega code, there would be somebody who would be with the mom.
Yeah.
Just with the mom.
But maybe initially, like when we all came in, it should have been, okay, you get an IV, you get this, you take care of the mother. You know what I
Typically,
mean? I
it's
think
that's more like I think when we deal with our adults, that's typically more like the team leader's role because the team leader, even though they're a crucial
Yeah.
part of the recess, they also have to be
They're
a huge
big
part
time.
of the department as well.
Yeah.
So that's more of the team
Yeah.
leader role. But I think you're right. Everyone was just kind of focusing on like, what the hell is this?
Yeah.
Sorry if I got on your nerves.
No, you
So-
didn't.
That was good.
And
though.
so was that
Very good.
due
No, but it
to
was good, 'cause
the
I
lack
could
of
actually
role
feel it.
assignment? Was that kind of why?
I think so.
Yeah.
Yeah.
Could've been.
Yeah.
So probably be more direct about you do this, you do this.
Yeah.
Was the mom a distraction?
Yes, absolutely.
Yeah.
Absolutely.
I didn't think so.
See, I totally felt she was a distraction. Yeah.
So if you feel you're distracted by someone, by something in the scenario, in real life, you say it.
Yeah.
Okay, this is distracting me, can someone deal with it?
Yeah.
And then you put someone on the mother or you deal with whatever the distraction is. Because you really need to focus and concentrate.
I think what Rory was saying was also true. Like I kind of noticed that she was there, but I know that we were working on airway, and then so I don't want to distract anybody that's already doing something. So, but I guess it's like we always do have that team leader, so maybe we take it for granted that
Yeah.
someone just takes on that role.
Yeah. So taking for granted, eh? Really commonly done in
Yeah.
recess scenarios, but we should never take anything for granted or assume something's being done. And if you think it, say it. One of the big lessons
Yeah.
in recess. If you
Yeah.
think it, say it. You're not gonna look silly, you're not gonna look stupid, right? It's all about the patient, for sure. I noticed, Lindsay, that you actually thought out loud a lot. Whenever you were troubleshooting the tension pneumo, the hypotension, you really kind of reasoned out loud. Was the team aware of that? Did you
Yeah. Yeah.
appreciate that?
Yep.
Yeah.
And that kind of brought everybody onto the same page. Do you think? You
Yeah.
all knew when you were putting the needle in the chest that you were doing it because there's a tension pneumo there, and that helped the patients, right? Same with the hypotension. You knew you were giving blood while you were giving blood, even though you didn't know where the patient was bleeding. You were giving blood because the patient was hypertensive. So I think that was well done. Why is it that you think out loud about it?
I think it's helps you to organize, my
Yeah.
only thought is just be systematic,
Yeah.
just always go through the ABCs, reassess, 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 what's the problem, what's the problem. And it's more for my own benefit, I have to say.
So I hear that a lot. When team leaders say they're thinking out loud, this is what they're doing, is organizing, they're following an algorithm, they're sometimes asking for help, for suggestions as to what's going on, and they're frequently reassessing. It helps them to reassess the patient. So those are all key features of thinking out loud, and it prevents fixation errors. Okay? Because the team is all on the same page, and if they think there's something else going on, then they speak up and say, wait a minute, what about this? Okay? So the team has to know what you were thinking, for sure. Great. The one thing I noticed, that it took about 8 to 10 minutes for this patient to get IV access. And it actually delayed your intubation. You were ready to intubate, but you couldn't because you had no access. Why did that happen?
Because I don't think we're used to the idea of an IO.
Right.
So we were sort of, it took us a few minutes, once we couldn't get a peripheral line,
Right.
to sort of think our way through it and go, oh, wait a minute, we've got the ability to use IO. here."
Right.
And I think it was like, but it took that processing time to think, okay, what's our next step here?
Right.
We've tried 3 times now to try to get the line, and we can't
Sure.
get anything.
Yeah. And Lindsay, you actually weren't aware
No.
that there was no IV access.
That's
So,
my fault.
yeah, well, not your fault, it's the team problem,
we
right?
should've-
Not the team. So
You
what,
know,
yeah,
that
where's the
wasn't being-
breakdown there?
I thought that was being said, but apparently it wasn't being said loud enough or
Right.
clearly enough to let you know as a strong team leader that we hadn't had the access. that we
Did the
required.
recorder know?
I did, and I said at one point, how many times have we tried now? And then someone said 2, and then I said, well, what point are we gonna do an IO? And then that's when.
Yeah, you started that.
That's when
Yeah.
someone said, let's do an IO, and I was like, oh, where's the IO? And then someone
Okay.
I moved to the desk, so then we did it. So-
Okay, alright. So there's some unawareness there on the, for the team leader. So part of that is communication within the team, saying no IV, no IV, and making sure the team leader knows. So what are some ways you can make sure you have a person's attention? How can you know that
Direct
what
eye
you're saying
contact.
is she's listening?
Yeah.
Direct eye contact.
State their name.
Say their
Lindsay,
name.
we have no line yet.
Yes, yeah, exactly. What if you don't know their name?
Green shirt.
If you have a hand.
Touch them,
Yeah.
touch them, get someone else to touch them, right? Make sure you have their attention when you're saying. And if you don't think they heard you, say it and say it over again, okay? Until you know. So that's important of closing that loop of communication. The other thing I think might have helped you be more aware of whether this patient had IV access is your position around the bed. We do a lot of these rule simulations, and what we find is that physicians in rural hospitals, this is not really rural, but in the periphery, they like to be by the side of the patient because sometimes they have to be, they're the only physician, but other times they just like to feel that they're touching the patient. They have to feel like they're more involved if they're touching. But what happens when you do that is you are really focused on what's in front of you and you lose the global picture. A few times I noticed that, stats had changed and you had a great recorder that were yelling out vitals to you, which is a good backup system because that made you then look at the monitor. But the stats had changed and you weren't aware until she said it. Because your back is to it and you're focused on what's in front of you. So what I suggest to some of these physicians is to, when you first go into the scenario or into the situation, listen to the patient. Put your hand on the patient if that makes you feel better, but then move to the head, move to the foot of the bed. Because then you're getting a global picture. If you feel like you have to be touching the patient, put your hand on the fetal pulse. That's all. You're touching the patient, you're getting some physiological response to your interventions, but you're seeing the monitor, you're seeing whether or not they're getting IV access, you're seeing whether the patient's intubated yet or not. You have a much bigger global picture of what's happening to the patient. I think that would have helped you know that this patient had no IV access. So, I just wanted to bring that up because that was an important step in this scenario that was delayed, but I don't think those are the reasons why. Any questions about the medical management of this patient? Okay.
Is there anything else you could do for this kid in a rural setting that would
So,
maybe save his life?
so the main problem initially was the increased ICP. Okay, so intubating, hyperventilating once you know he's coning, right? That Cushing's triad. elevating the head of the bed.
Okay, yeah, we did
Right.
bring 30 degrees.
I heard mannitol, you gave mannitol, right? At CHEO we give 3% saline, just because it's more cardioprotective, so it doesn't cause the hypotension. It's easy to give, you can just push it in a syringe, it doesn't need to go through a filter like mannitol does, so it's much easier to set up and give. And the dose is easy to remember, 3 cc's per kilo for 3% saline. Okay, so we use 3% much more frequently than mannitol. Alright, so that's the only thing I would recommend for that. Regards to the other, you manage the hypotension, you manage the all quite fine.
Do you guys keep that 3% saline in your?
Resus?
Yeah.
I think it's here too.
Well,
Both
yeah,
rooms
we
that
actually have to
said
get it
it's here.
secretly
We
through
have
pharmacy,
special
all these
access through our name cupboard.
Oh, I
After we
see.
talk to the pharmacist, it's actually,
Oh,
But we
so
have
it might
mannitol.
be wise
Yeah.
to get someone on.
yeah, I know our pharmacist has been trying to get.
We used to have.
Well,
it.
Irene is in on this today, and she's part of the best practice of pharmacy, whatever, so, she might be able to take that back to them, to her committee.
Yeah.
Does anyone
Okay.
want to use it for bronchiolitis?
Yeah.
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 Yeah, sometimes you just put it in a mask.
Yeah. Interesting.
Okay, any other questions?
That was a good, it's a good exercise.
Yeah, simulation is great, eh? Like, it really humbles you. Yeah.
It's real.
And when you make it,
That's
when you make
good.
it feel really,
Yeah.
yeah, you guys were very.
Helen deserves an
Just
Emmy,
thinker.
she's very good,
Yeah, yeah,
yeah,
Helen.
at being the